Well, hey there, Susan here, and welcome to today's episode of the Menopause Health Podcast. And I am so excited you're here. We are going to talk about to pellet or not to pellet today, because that is indeed the question. It's, so many of my girlfriends were out and they're, especially my girlfriends in their late 40s, and they're like, oh, my friends, they need to be on pellets. Well, our expert today might have a different opinion for you. And, it's going to be very interesting. We're also going to talk about cardiovascular health. We're going to do a lot of statistics, some kind of scary, but don't worry, we end on a high note because we're going to give you some great recommendations of how you can take back your power in menopause. And my guest today has over 30 years of experience as a health practitioner. She is a certified nurse practitioner and did her doctorate. She also studied AI at MIT. She is certified with the Menopause Society. And on top of it, she is my co-founder at thepause.ai. And if you haven't checked out the app yet, it is live in the App Store and it offers you a 24/7 menopause support companion. Her name is Hormone. You will, when you're onboarding, you'll get to find out what stage of menopause or perimenopause or postmenopause you're in. I actually was surprised with my stage, to be very candid. I didn't realize that. And it's gamified, so you can earn fun badges. You can integrate your Apple Watch. We will also be integrating all the other wearables coming up as a fast follow, but it's amazing. It's in the App Store right now for only $29.99 for the entire year. And that is a significant savings because after our first 350 founding members, it will go up to $89.99 for the year. It's still incredible value. We have so many great things coming with our feature roadmap, but we want to reward the early subscribers. So go to the App Store and download the Pause app. Just simply search the Pause Menopause app or go in the show notes for the link. So with that, let's get into today's episode of the Menopause Health Podcast with the amazing Dr. Mia Chorney.
Welcome to the Menopause Health Podcast, your go-to resource for practical advice brought to you by credentialed health professionals and industry experts. Here is your host, Susan Sly.
So Mia, oh my gosh, okay, here we are, and we're already almost at the end of season 1, and this is the first time you and I have had a minute to sit down and chat, and I almost feel like we should be, I don't know, having dinner or coffee. So we're going to have that kind of conversation for the world to hear. I want to jump right in, and we know that there are 3 kinds of menopause. So there's the natural kind of menopause a lot of people are talking about. Then there is surgical menopause. So a woman has a hysterectomy. And then of course there is chemopause. A woman's having chemotherapy. Your menopause journey is very unique, but it is not unique to you. And I would love for you to jump in and share how you went into menopause.
All right. Thank you, Susan, so much. Really thrilled to be here today. So I'm going to share with everyone my menopause journey occurred at 32. I had to have surgical menopause. So I was struggling with some health conditions, and it was medically recommended that I go through a surgical menopause. So that means removal of my uterus, Susan, and both ovaries. And so when a woman goes through that at no matter what age, but 32 for me, it's like drastic. The next day I was full blown menopause and starting to already have the symptoms of vasomotor symptoms. Within 1 week, I knew I was in full menopause, hot flashes, night sweats, you name it. It was quite, I don't know how to describe it, kind of overwhelming. You just can't imagine.
And what about when you say overwhelming, to think about a young woman, to think about that, that ending and think about the resources then. We didn't have TikTok. We didn't have Facebook.
Yeah.
There was no, there were no online communities to really discuss that. How did you navigate that emotionally?
That question actually almost brought a tear to my eye because I want you to know I was not prepared for it. So at the time I worked in healthcare And when I went to go to sleep to actually have the procedure, one of the directors came in the room and held my hand. And I was crying when I was about to go to sleep because, number one, I had a 6-month-old baby at home. Number two, I knew I would never be able to have children again. And number three, I wasn't sure I was ready for what was ahead of me. Didn't have any idea how I was going to navigate being a 32-year-old woman with 2 small children, now in menopause, and a lack of resources. So it was, seriously, it makes me, really emotional to think of how there was no resources back then to support a woman.
No, and how did you do it? What did you do? There are, right now there are women listening to this, or, people, maybe friends, and I would just encourage you to share this with women who are either contemplating a hysterectomy or they have been told they need to have a hysterectomy, because again, this lack of support. And we're also, even in today's time, I had a young woman who had a hysterectomy, but she had a hysterectomy due to a very serious medical condition, and she was gaslit. She, and I don't know how much has really changed, in this time, Mia, but what did you do, and what advice would you give to someone outside of online communities and things, because that wasn't available?
Yeah. Back then, my gynecologist tried to navigate it with me, but again, he wasn't sure what to do. To complicate the issue even more for me, when I had the surgery, they couldn't get my cervix out. So here I was with a woman with no uterus. I had both ovaries, but I still had a cervix. And so that's not very common. And so I was still at risk for cervical cancer. So they were trying to figure out what hormones I could be on, what hormones I couldn't be on, what was the current treatments that I could be on. So I did go on hormone replacement at that time. If you remember back in the day, that was Premarin. So estrogen created from horse mares, right? Those sort of things. And I went on progesterone, but they weren't even sure how long I could be on. There was so much controversy from the Women's Health Initiative study that they let me go on for about 2-3 years. And then he just kept saying, I really don't know if it's safe or not. I'm really not sure what's the right answer for you. So I was completely lost. I was literally bouncing from a couple of providers who all said to me, we're not sure what to do with you. We're not quite sure what the recommendation should be. So I did stay on hormone replacement, prescribed hormone replacement for about, I would say, 8 years. And then everybody got nervous. Everybody wanted me off. But remember, I'm still 40. I'm 40 years old. I should be just kind of thinking about getting into perimenopause at this stage. So I again started provider shopping and jumping and jumping and jumping. And I got to a point where, because of my age, Susan, when I was 45, nobody wanted to give me anything. They're like, it's too long to be on hormone replacement. We don't feel comfortable with you being on anything. So there I was at 45, in back full-blown menopause. But I was high risk because I'd had my ovaries taken out at 32 for bone health, heart health, all those sort of things. And so I ended up getting every symptom in the world possible. As you know, we've discussed that. That's why we're here today. Back, everything from fatigue to weight gain to, urogenital symptoms that were very difficult to navigate. And I was a lost soul out there. So for our women today, this is why you and I are here. We want to make sure we're educating our women of those resources and where they could be going if they are like me, that lost soul out there, just feeling so literally anguished and feel like I'm suffering in silence and I don't know where to go.
And then that piece, there are so many women suffering in silence. And let's jump into some statistics, because it is quite startling. In the previous episode, we had Andrea Campbell, who's a nurse practitioner out of Canada. She's also certified by the Menopause Society, as are you. And she was talking about some statistics, especially as they relate to Canadians, and which is 50% of our audience. But let's talk about statistics in the United States because there is a provider deficit. You're talking about not getting the appropriate support. Even now, I know there are people who reach out to you on LinkedIn and they want to come and see you because they're looking for someone who's certified in menopause. So let's share some of the Startling statistics, and including starting with how many women are entering menopause every day and what that certified provider to patient ratio is.
I love this statistic. This one gets me jazzed, and this is why we're here. 6,000 women each day enter menopause. So imagine that, Susan, 6,000. So if we look at the ratio of current menopause certified providers here in North America, that would mean that each person who is certified, like me, would need to have a patient load of 30,000 patients. That's not possible right now in our current healthcare, statistics that are going on. And that ratio, like 6,000 a day. What are we going to do about that? We need resources.
Yeah, and a deficit of 30,000 patients. I mean, it's per provider. It's not possible. And one of the things that Andrea and I spoke about is this journeying by yourself. And that is why we created the Pause AI app, because it allows for 24/7 menopause companion harmony that women can get answers from, that are vetted, and to be able to get that support while they are finding the right provider. And you and I have heard stories in our cocktails and conversations where women go from 2, 3 providers, 5 providers, and they're just getting the runaround. And who has the time? And every time you go to a new provider, you've got to fill out all the dearth of forms and everything. I'm like, oh my gosh, like that's a whole other conversation. So yeah, I want to talk about this some of the myths that are out there right now. And I know pellets are a big one. You and I have girlfriends, we'll be out for dinner, and these are women in their late 40s, and they're like, oh, my girlfriends say I have to be on pellets. And I actually, I have girlfriends who say that too. Let's talk about pellets. Please explain what they are, and give some insight into them for people who don't know what we're talking about. We're not talking about things you feed bunnies or something. Like, we're talking about hormones.
Yeah, so pellets are one form of hormone replacement that women have been given an option to get. And so a little cannula, a woman gets like a little poke in her upper butt cheek, a little cannula is inserted, and these little pellets, so just imagine little round balls, are dropped down through the cannula into your buttocks cheek, and they sit there for however long, 3-4 months. They gradually dissolve, and the idea is to replace, your estrogen or perhaps your testosterone. For me, I'm going to disappoint a lot of your listeners today, but I do not recommend pellets whatsoever. So pellets are not FDA approved. And so that's really important when you're going to be looking at trying to get your hormone health and your symptoms well controlled. I really do want women who are going to look at hormone replacement to make sure they're getting medications that have been tested, tried and true. We know we can put it in, take it out, adjust it, those sort of things. And unfortunately, pellets, they can't be removed. You can't be going down there and trying to find them and remove them. So that's really important. And as we know, pellets, the reason they're not FDA approved is because they're compounded. And so compounding means we're not quite sure what those ingredients could be from user to manufacturer, right? And so what are the fillers and all those other contents in there? So I think that's really important for our listeners to know that if you're going to want to be getting hormone replacement, go with, perhaps the patch is always my number one recommendation. Start there, or vaginal estrogen, if it's vaginal dryness or symptoms that we're dealing with. But there is some really beautiful options that can be started and stopped and, titrated for us. That is considered much safer and has better efficacy. We love that word, best practice, right? You and I love making sure when we're educating everyone, we're giving them best practice knowledge.
Well, and pellets, it's so interesting too because I had one of my girlfriends. She's a subscriber to our Pause app, and she got pellets, and we were out for dinner, and she was like, "Susan, I got pellets 3 days ago. I don't feel like myself," and and again, there could be a lot of things going on.
Yeah.
That's why you really need to speak to a certified provider and get the right choice for you. Now, this is a show where I just air my stuff, right? So I did get the patch, and because I work out a lot and I love hot yoga, the patch was not for me because the patch kept falling off.
Yep.
So guess what? If it falls off, it's not actually doing anything. So I've done it all. I've done the suppositories. I've done, you name it. So now I'm at the creams, and I do a testosterone injection, and that really works for me because I did love the patch, but if you're going to sweat a lot, it might not be for you. That's my
Exactly.
experience. It slips off like Teflon. Like it's just not. It's not happening. Mia, let's talk about surprisingly, it's a very small percentage of women who are on hormone replacement therapy. And in your opinion, as a practitioner, why is that? When we know that women do tend to feel better when they get the right regime for them, we're not, again, we're not here to recommend what regime you do. You need to work with your practitioner who's
Yep.
going to look at your health history, but it's a surprisingly small percentage that are actually on HRT.
Yeah, so HRT absolutely, current prescriptions are less than 6% across the North America right now for our women. So that is happening, very honestly, for lack of increased knowledge for providers to know what they should prescribe. Is it safe to prescribe? And I don't want to say anything negative about my colleagues, because absolutely, when you take on a role, it's hard to stay up on everything that's going on, right? We got to do a lot of reading and a lot of conferences. But what happened is back in 2002, there was a study called the Women's Health Initiative that came out saying that hormone replacement therapy was unsafe in women. And so if we remember, Susan, we remember Times Magazine, Maclean's Magazine, man, it was all over the covers, Bazaar, Glamour, telling everyone to get off of taking any kind of hormones. But now in retrospection, these studies, they've seen actually the data was not as clear as they thought. Most of those women were over the age of 65. They were not perimenopause and menopausal. So now all the new data has come out actually reversing, saying that for most women, hormone replacement is safe for a lot of women. And so we just need providers to know the new data, and we need to get out there. Most providers are not trained in menopause. I wasn't trained in menopause specifically, and we know that the majority of gynae, internal medicine, it's not part of a big, robust part of their program for them to be up to date. So we have a lot of work, Susan, to do to get everybody educated, both us as users and patients within, but also with providers. And I see that happening. Massive shout out to the Menopause Society. They had their first ever sold out conference, Susan. And so I never go to a conference that it's sold out, but this conference was sold out. So we're definitely on the radar, and we're definitely seeing that people are wanting to learn more and make sure they're up to date. We see it everywhere in social media right now.
Absolutely. And I'm going to have a whole episode dedicated to research coming up, which I'm super, super excited about. There's, one of the questions that comes up is, so why isn't, this is the Menopause Health Podcast. We know that people listening I get LinkedIn messages, I get DMs that there are practitioners listening who want to be educated. There are people listening who are going through perimenopause, menopause. The question I have for you, Mia, is why is it now that we're finally having a moment, considering that this is the only inevitable health condition every woman will have? Not every woman will choose to have a baby. Not every woman actually menstruates. Some women don't. Especially, I used to be a professional athlete. A lot of track athletes, gymnasts, we didn't menstruate because we were training so hard.
Yep.
So why haven't we had the right research and the right data? Like, why is it just now that we're starting to have the conversation?
Yeah, well, research has been lacking in every field in women's healthcare across the board, right? It wasn't until 1997 that the National Institute of Health actually started mandating that women were to be included in trials. And so if you look at all research literature across whether it's cardiovascular disease or anything, we tend to be less than 30% of all participants in any kind of study. I think why now, Susan? Because of people like you, me, the people out there in our audience. They're demanding answers. They're looking, they're speaking up. Women are finding their power and they're wanting to learn more. And so you can see right now that we realize menopause is 40% of your life. And like you said, it's inevitable. We don't evade it. We're going to hit perimenopause and menopause at some stage in our life. So I really think it's why now is people are speaking up. They're asking for more data, more support, more education. And, you can see it with what we do, social media, healthcare organizations, all these massive provider advocates throughout the country. Massive shout out to all of us for speaking up. That's the only way we're going to be able to move action.
Yeah, and you said that, women are less than 30% in any trial. And that's a challenge. As women, we have a lot going on. We're often wearing multiple hats, and we might be, dealing with, in this generation, Gen X, we're dealing with aging parents. We are dealing, perhaps children, partner, pets, career, all of these things. I just published a blog that it's staggering. 56% of women at middle age are leaving their tech jobs. So it's, and you think, okay, you went to school, you became an expert in a specific area of tech, and you're really at your prime, and 56% are leaving. And, one of the big correlative studies is that women, and this came out from McKinsey in their women's health report for this year, said that 41% of women feel they aren't getting the support through perimenopause and menopause, and these things have to change. So as women, we need to stand up, and we need to have our voices, and we need to be also have that willingness to say, yes, if I do participate in some kind of a trial or a research study, that my data does matter. It really, really does, for our daughters and our goddaughters, and all the generations to come. I want to talk about heart health. So you work in cardiology, and in the United States, cardiovascular disease kills more women than the top 5 cancers combined. And could you share some of the staggering statistics? Because a lot of women, they think about, they think about how they look, but they're not necessarily thinking about heart health. But you see patients every single day.
I do. So heart disease is the number 1 cause of death globally, but also I want to speak about the United States stats. So it is the number 1 cause of death of all women in the United States and in Canada. 1 woman, Susan, dies every 80 seconds currently. And so you were saying all cancers combined don't equal the death rate for heart disease. And I want to say cancer is very important, very, very important. But most women don't equate poor health or risk of disease or morbidity or mortality with heart disease. We know that 50% of women have no idea that heart disease is their number 1 cause of death. And I also want to stress this is also in our maternal population. So in our pregnancy population, what is the number 1 reason a pregnant woman would pass away is due to cardiovascular reasons. And in the United States, we have the highest death rate in the maternal population of any developed country in the world. So it's my passion, as you know, to get out there and work in preventative medicine, educate, advocate for women everywhere and globally. And because I have a heart history, and your viewers don't know, but I had a heart history at that same time at 32. There's something about that age of 32. And that is actually one of the reasons why I had to have a hysterectomy and my ovaries taken out. They kind of all tie together in what was going on at the time. So we want to educate our women and make sure that they're aware.
Now, Mia, the heart piece is so prolific, right? And I think about this has nothing to do with women, but it does because as you know, one of our good friends, Erin, it was Mother's Day, and the next day, and it was Saturday, and she and her daughters went up for a power walk, and then she and the girls and her husband were going to go out on the boat that night, and her husband was at home, and the girls got back, and he was dead in the lawn chair. And this is a guy who's fit. He was my husband's age, and I think he was 54 at the time, and he died of a heart attack. And they call it, for men, the widowmaker, but it's the widowmaker for women too. And we think there's a lot of sort of traditional things we think about in terms of protecting our heart, especially in, perimenopause and menopause. But what are some of the things that are very evidence-based that we might not be thinking about that we could leave the show and be like, I'm starting to do that today?
Okay. First thing I want to tell everybody is know your family history. Do you have any risk within your family history? High cholesterol, high blood pressure, history of heart attack, history of stroke, history of aortic problems, dissection. I want everyone to know their health history, and I've worked on my health history for my children. I've written it out. It's called a pedigree. I want them to know. So when they go into their doctor and establish care, they need to know, what does their mom or dad have? What do their grandparents have? And we always want to know what your parents have and what your grandparents have and your siblings, right? So we inherit one gene from mom, one gene from dad. And so we can inherit risk factors that could contribute to cardiovascular disease. The other thing I want everyone to know is you need to maintain a healthy lifestyle. There's no question, we call it polygenetic risk. So let's say you inherited a gene for elevated cholesterol. We know if that person can work on environmental contributions, they can make a big difference on their cholesterol or their risk. So how much exercise are you getting? We should be getting 150 minutes a week of moving our body. So really focusing on that. And you talked about, when we're midlife women and we're really active and we're working a lot, sometimes that's really difficult. So I literally tell my patients, I want you to schedule it in like you're going to the dentist appointment 5 days a week, right? You wouldn't miss it, slot it in and make some time. But just be aware, are you a morning person or a late person? And start scheduling that in. The next thing I would tell my patients is really make sure that you're reducing your risk factors. Do you smoke? Do you vape? How much alcohol do you drink? All those things that can contribute negatively towards our cardiovascular health or our women's health. We know alcohol contributes to risk of breast cancer. We know smoking. We all know those things. I don't know if you know, Susan, but in our younger population right now, we almost got rid of smoking in our younger population. And the latest data through the American Heart Association shows that smoking is rampant again in our younger population. I know. So they're all vaping and they all think vaping is okay, but we know that vaping's not okay. So we are terrified about how we need to re-educate this population. It's very, very high, the smoking that's going on. So we've got this population coming up of our young adults right now. The next thing I would say to people is know your blood pressure. You absolutely want to know your blood pressure. We call hypertension the silent killer. And a lot of people are just not aware what their blood pressure would be. It's changed a few times over the year, the guidelines, but your blood pressure should be 130 or less on the top number, 80 or less on the bottom number. And most people don't know that. They think it still is okay to be in the 136, 140s. It's not. That's not good for your brain, your eyes, your heart, your kidneys. You want to keep it down. So just looking at all those things. And finally, Susan, I'm a big one on, we talked about what we eat and also how we sleep. Those real basics that we forget every day. What are we eating? And are we sleeping? if you're not getting your sleep, your cortisol levels are high, you're eating poorly because you're tired, you're looking for comfort foods, perhaps high fat, high sugar foods, trying to get in that bliss area to make yourself feel better. And those are the basics, and what we're doing, Susan, for our heart is what we do for making sure we're giving good perimenopause, menopause care, what we're doing for diabetes, what we're doing for high blood pressure. They all link together. I say to everybody, I want you to think, how did your great-grandparents live? They didn't use remotes. They didn't go through the drive-through. They walked. They cooked healthy food out of the garden, all those kind of things. And we really need to kind of get back to basics.
Absolutely. Get back to basics. I love it, Mia. And as I always write notes, and you're my best friend, and I have 2 pages of notes. So what does that tell you? I was like, oh my God. And that, that piece, this is why we created the Pause app, because it's, yes, you track these things and you're integrated with your wearable device. And then it's not just tracking it, it's knowing what to do. And that's why we have the AI component, Hormone, that provides the 24/7 guidance.
Yes.
You and the board of medical advisors have tested her, continue to test her. And one of our investors, her doctor said, you've got to get healthy. And he suggested a specific kind of diet. And she was like, where do I turn? She goes, I'm going to ask Hormone. Hormone wrote her out a whole diet plan. She also made sure that it included locally sourced foods. This particular person is in Canada, in Alberta. And she called me. She's like, oh my gosh. And Hormone will speak Spanish. She speaks Italian. I test her in Japanese. She speaks everything. And to be able to do that, because it's not just a matter of tracking, it's a matter of knowing what to do. Because one of the things I've learned in my own health is it's never too late to get started. And, we can always start resistance training. If people haven't heard the episodes I did with Dr. Paul Arciero and Dr. Jen Burke, we talked about resistance training. We talk about lifestyle types of exercise and so on. And that's what we're aiming to do. And so, Mia, any parting words for the listeners?
I do want to do a parting word. So I used Hormone last night, Susan. I've had a really hectic week and I was tossing and turning, lying in the bed, could not get my brain to settle. And so I got my app out. I needed her last night and said, "Okay, give me some tips outside of what I've already done to help me, be able to turn my brain off." It was just going, it was just buzzing. And so I can't stress enough, even as a healthcare provider, I used Hormone. I got on there. Sometimes it's really beautiful to have that impartial friend, and I call Hormone my friend and get on there and ask her some questions. She was available. I couldn't call you. It was 11:30. We knew you were in bed sleeping. So I used Hormone, and she was fabulous. She gave me some interesting meditation. I utilized it, turned it off, and I was very grateful to have that companion at 11:30 at night.
Absolutely. We all need that, the impartial friend, that companion. As you know, I was in New York and I had landed and I'd been flying like crazy. And I just couldn't get my brain to stop. And so Hormone was like, well, do you want a breathing exercise? And so she walks me through a breathing exercise. Like, yes, Hormone, thank you. And I was able to get to sleep, and I had a really great sleep. And that's why we created this platform. And if anyone listening wants to know more, just head on over to www.thepause.ai, go in the App Store, search the Pause Menopause app. You will find the app, and it looks like the pause button, and check it out. And our first 350 subscribers, they will get the app for only $29.99 in the United States for the whole year. It's available in the US and Canada, and we will be going into Australia as our next market, but definitely check it out. So Mia, thanks again for being here. It's about time we did this.
It was great. Thank you. It was so much fun spending this time together.
Well, thank you. And hey, everyone, we're in season 1. Check out the previous episodes, future episodes, share this with everyone, tag us on all of our social media. And with that, I will see you in the next episode.
This Menopause Health Podcast is brought to you by the Pause Technologies. To find out more, visit thepause.ai and follow us on your favorite social media channels. Don't forget to hit the subscribe button, share the show, and connect with us. We will see you in the next episode.